Hello, everyone, and welcome to today's CAP webinar on depression. In the interest of time, we'll go ahead and get the introduction started. We're privileged today to have two wonderful speakers. Dr. Hohui Eileen Wang is an assistant clinical professor of psychiatry here at UCSF in the School of Medicine. She practices clinically as a child and adolescent psychiatrist in the Division of Mental Health and Child Development at UCSF and Children's Hospital of Oakland, and in the Division of Child and Adolescent Psychiatry in the UCSF Department of Psychiatry and Behavioral Sciences. She provides clinical care in the outpatient clinic at UCSF and Children's Hospital Oakland, as well as the UCSF Medical Center at Parnassus Heights, now down in the Pritzker Building in Mission Bay, and serves as a consultant on the UCSF CAP portal. Shelly Nakaishi is a pediatric nurse practitioner at UCSF Benioff Children's Hospital Oakland, Department of Psychiatry. She helped to implement behavioral health integration program in the Children's Hospital Oakland Primary Care Clinic. She also serves as a consultant on the CAP portal and is a frequent instructor in CAP CME programs, along with Dr. Wang. Her clinical and research interests include suicide prevention and trauma-informed care, with a strong focus on health equity. And with that, Drs. Wang and Nakaishi, please take it away.
Thanks, Joanne. We have a small group, so we'll try to make this as interactive as possible. If things come up, we can help address them relevant to the slides. And then hopefully we'll have 10 minutes at the end to have more discussion, open discussion. And our objectives today are to go over the validated screening tools for assessment for depression, talk about the AAP guidelines for treatment of depression in primary care, including going over the diagnosis and co-occurring conditions that often happen. And we'll talk about severity levels and treatment approaches for depression, and then a guideline for starting and monitoring medications for depression. This webinar is really just focused on pediatric depression in primary care. We do have separate trainings and webinars on suicide and on SSRIs. So we briefly may discuss them here, but we have hour-long presentations on suicide and on SSRI treatment. Okay, next slide. So for disclosures, no one has any financials to disclose, although the CAP program is supported by HRSA. Next slide. So in context for depression, it's an estimated that 1 in 5 youth have experienced depression by the age of 18. And actually during the first year of the pandemic, there was a 2021 article in JAMA that estimated 1 in 4 actual youth globally experienced depressive symptoms. And a major challenge is that 60 to 80% of depression in adolescents goes undiagnosed and untreated. And what we do know is that primary care providers are on the front line to manage this challenge. And there are so many barriers to for mental health treatment. One is stigma, and the other is systems barriers, insurance being one of them. But one of the major advantages in primary care for treating depression is that youth are seen regularly, and they trust primary care providers. So it's also validated that treating mild to moderate depression in primary care is effective treatment. And we do know that if depression is untreated, the major risk is around suicide. And with that, like 1 in 5 American adolescents have had a suicide attempt that requires medical attention, and that suicide continues to be the leading cause of death in ages 15 to 24. Okay, next slide. So major depression in teenagers, the typical onset is around 15 years of age. In teens, females are 2 times more likely than their male counterparts. And that when they're younger children, it's actually more equal between the genders. But depression is also more rare at about 2%. The average duration of depression is 7 to 9 months. And in 2 years, about 90% are in remission, but relapse can occur in about 50%. So that's why it's really critical to continue to monitor symptoms 6 months out. And of about the 20 to 50% of depressed teens, they have a parent who has also been depressed. And this is important in knowing and gathering family history, mental health history, because it helps us to rule out other co-occurring conditions or something like bipolar, but it's also an opportunity to find out about family and cultural beliefs, about how they feel depression is started, how they might treat it within their culture, family, and of course, if there was any medications used to treat parental depression, that can be helpful in helping us to decide which one we might want to use based on familiarity. Okay, next slide. And so can depression look different between children and adolescents? I mean, depression can look different in anybody. But in general, the key, sadness, irritability, and anhedonia are consistent. But irritability symptoms for teens and young children are much more prevalent than, let's say, in the adult population with depression. And the key to irritability is, because we know our kids can be irritable, is that it's persistent and it's out of the normal range for their developmental age. With younger children, we do tend to see more somatic complaints for depression, more separation anxiety, and much more disruptive behaviors. So the disruptive behaviors, there's a lot of co-occurring things that could be causing that. But one of the first questions we should ask is, do they feel sad? And with adolescents, we tend to see more risky behaviors and more feelings of boredom and an increase in suicidal ideation. Well, what's helpful for all mental health conditions in children is to really, you want to get a direct report from the youth themselves, but you also want to get collateral. You want to get the information from the parent, the caregivers. And oftentimes, youth are not going to tell their anyone that they're depressed, but they may write it. So it is good to have some of these screening questionnaires in a written format. Okay, next slide. So what is, depression? What is normal sadness? And, that I would first start to ask them, the youth themselves. But the other factors are really about the functional impairment. And that'll be a consistent theme is how is this impacting them in school, in their social life? Are any risky behaviors happening? And then, of course, we want to consider around suicidal thinking and safety as well. But depression is often very gradual, but when it happens in a more rapid and consistent way, that's more alarms that are going to go off for us. And we're going to do more assessment and more safety assessment as well around suicidal behaviors and around risky behaviors as well. And, it's going to be often there's some stressor that may have this occurred as well. Okay, next slide. The AAP has, there are the GLAD PC guidelines that have been around, I forget the year, but it's been around for a while, about really indicating that in pediatric primary care, the screening and treatment of adolescent depression is effective treatment. So we pretty much are following that with the webinar today. Next slide. Okay, so screenings. This is the challenging part in well-child visits. It is recommended to screen for depression in adolescents. And there are so many screens that you're being asked to do in well-child visits. And you have to juggle so many things. So, often we see in primary care clinics that there's a PHQ-2, and then if that's positive, then a PHQ-9 adolescent is given. And if there is some suicidal thinking on that, then they ask screening tools used for around suicidal thinking. And we have some trainings on suicidal assessment as well. But that's typically the flow that we see around depression screening for teens. And then for younger youth, 6 and older, there is a short mood and feelings questionnaire. And oh my gosh, another questionnaire to use. But I really think of these questionnaires these rating scales as a guide so that you don't have to make sure you ask all the right questions or set it in a developmentally age appropriate way around how a child might be feeling depressed. So it just is a guide to help you ask those questions. And then how do you do all this? And you are a master juggler, basically, and a detective. And so, you know, it's hard to get all this done and say all the right things and make sure they have the right support at the right time. Part of this juggling act is to, you know, validate their feelings, thank them for sharing them, and then ask if they can set up a follow-up appointment. And the additional screens can be done, and the additional psychoeducation can be done, and assessment for more focused talking about the depression after the well-talk visit. I hope that helps alleviate some of the processing and time constraints that you all face. Okay, next slide. So, I did want to say for the short mood and feelings questionnaire, there's a parent version and there's a child version as well, and they are free. You can find them on the website. Okay, next slide. So evaluation tools. A lot of this is already embedded in primary care. You do the shades or the heads to find out the psychosocial history, which is the risk factors and the protective factors. And that is critical in figuring out what may be causing the depression and how is it impacting their functional impairment. So those are the clues that are happening when you're doing your heads. And then, you know, there's the ACEs screen, or just, of course, you're going to be asking it for any acute stressors or chronic stress or trauma history. And that a lot of that time comes up in the heads. And if there is some mood component going on, it's checking in around a suicide assessment and safety. A critical part of that is around lethal means counseling. That's the, you know, most suicide attempts happen within 10 minutes of the thought. So if we can actually prevent access to lethal means, we can prevent death. So that's the critical part of the safety planning. And then the last part of the evaluation tools is around the DSM-5 criteria for depression. And we're going to talk more about that in a few more slides. Next slide. So some quick tips around depression screening and talking about depression is first and foremost is always to bring up teen confidentiality in the beginning of the visit and to make sure that's reviewed. And I like to interview the patient and the parent together first, if the parent is there. And then I interview the parent separately and then the patient last. That way the teen may not feel like I'm disclosing information that they disclosed to the parent. That's, of course, if you have time to do that. And then it's really asking and asking the teens very specific questions. You can review the PHQ-9 with them and also normalize that this is something I ask all my patients, and that, you know, if there is some struggle that, you know, oftentimes people can feel sadness, and does this happen for you as well? And working with youth is you know, trust your gut, and if something's not feeling right, is to really get the collateral information as well. And let's see, next slide, please. So, okay, hopefully most of us are familiar with the SIGI CAPS, which is the acronym used to kind of go through the DSM-5 criteria. It talks through any sleep changes, any changes in interest, any guilty feelings or worthless feelings, what's the different level of energy, fatigue, or maybe more restless, impacted concentration, changes in appetite, any psychomotor agitation, and then suicidal ideation. And also, just, you know, if you don't remember that, also in the PHQ-9, it pretty much follows those same symptoms. But the critical part of depression is that they feel depressed, that they feel hopeless, and or that they may have irritable mood that's specific to youth. that's been consistent and persistent for 2 weeks or more. And we know we can feel depressed for 2 weeks ourselves. And it's really helping to look at the big picture. How long has this been happening? How is this impacting you? When did this start? Why do you think it starts? It's kind of your evaluation. You're using the same kind of questions that you might ask when someone has a headache. When, where, how long, what makes it worse, what makes it better, what are you eating, what are you doing with how is your sleep impacting this? When I start to put that kind of detective hat in and I ask those questions, balancing it out with being validating and empathetic to the emotions too. That's the art of the evaluation. Okay, next slide. This is just a general guideline. How severe is the depression? And when do I need to do something in primary care? This is just a general to say, like, it's based on the number of symptoms. I really think it's about based on their impairment. How impairing is this? And also based on how much they want help. So that's kind of how I hold that. And then the level and what you do for treatment, Dr. Wang will be going over that next. Next slide. Some other factors to think about in evaluation. I did talk about the family history and understanding if there's a genetic component, checking in if there's things to consider for possible bipolar. You've done the psychosocial assessment with your heads and finding out what's going on environmentally. And then I've also it's important to kind of understand culturally in their family, how they feel about mental health, about medications, and where they stand in that. Because it could take a while for them to seek out treatment. And it could be a dance that you're doing over a course of time. And then the other factor of a part of depression could be like a persistent feeling of self-esteem, negative self-esteem, or negative or thought distortions are part of depression as well. Next slide. So this is a slide, pretty colors, and with also kind of saying that more often than not, there's a co-occurring condition. Some of these could be the cause of the symptoms of depression itself and not actually depression. So to rule these out, you can use these. These are just examples of some other rating scales you can use to help rule these out. And of course, you're not going to do this in one sitting. It's going to be a process. That's the luxury in psychiatry. I might get 60 minutes to 90 minutes to do my intake, and you have 15 minutes. So you're going to be doing this kind of evaluation over a course of visits. But these are just helpful rating scales. I do think it's important to find out the severity level of the depression if there's any psychotic symptoms. Not to miss that. The other one around irritability and disruptive behaviors, we definitely want to rule out ADHD. We want to know if there's any substance use that they could be using as a coping skill, or it could actually be causing them to be depressed. And one not to forget is around eating disorders. And that could be often in conjunction together. So these are all the things to consider, either that they're co-occurring or they could be the cause of depression or the symptoms. Next slide. So this is just another layout to think about things to evaluate for. And it also includes the physical and medical conditions to consider and to do labs if you're have a sense that this could be a consideration. And then not to miss out if there's pregnancy, it would be one of the other ones. And then also other medications could be causing some of the depressive symptoms. Steroids, seizure medications, some birth control medications. Okay, next slide. Doing okay on time. And then this is Handing it over to Dr. Wang.
Thank you, Shelly, for introducing depression screening and diagnosis, incorporating the GLAD-PC guideline from the AAP. I'll be taking over to talk about depression treatment and management. And as Shelly mentioned earlier, we have separate webinars for SSRI and suicide assessment. I'll talk a little bit about these topics, but I won't go into details, and we will have upcoming separate webinars for those topics. So as Shelly mentioned, when we're screening and diagnosing the patient with depression symptoms, we sort of think about mild, moderate versus severe level of their depression. And for the mild patients, we will use active monitoring and psychoeducation. GLAD-PC recommends following these patients up for 6 to 8 weeks, and then check on them every 1 to 2 weeks, and then over 6 to 8 weeks, if they have completely resolved, then you can just monitor and regularly as you would regularly do for your other patients. For the moderate patients, we'll recommend starting SSRI and therapy concomitantly for 6 to 8 weeks and try to see if there's any meaningful improvement. And then for the severe patients, we will recommend to refer to mental health specialties. So we will talk a little bit more about active monitoring and psychoeducation, SSRI, and therapy in the rest of the slides. For active monitoring and psychoeducation, we would try to cover these components. So basically, it includes psychoeducation on the cause of depression, what are the common symptoms, the etiology, the onset age, natural history and expectations for recovery of these symptoms. We'll also do safety planning, suicide assessment, and lethal means counseling. If you feel the patient is at risk for self-harming or suicide. And also we will provide patients for options for other types of assessment if we are considering differential diagnoses. And then we'll introduce what are the treatment, including therapy and medication if their symptoms continue to worsen, and then what is the plan for active monitoring. These could be referring them to supportive counseling, helping to facilitate parental and patient management of their symptoms, start behavioral activation, refer them to peer support group, and then monitor their symptoms every 1 to 2 weeks via phone or text messages, secure text messages about their depression symptoms and suicidality, and then also potentially connecting them to therapy. And then the tips to kind of conduct active monitoring and psychoeducation really is to first try to see where the patients and the families are at and just meet them where they're at. They may come from very different cultural belief, religious belief, and having different stigma in their family, and it all may impact how they view the depression symptoms and how they accept different options that you offer to them. And I find it really helpful to normalize and say, you know, there's like 1 in 4 or 1 in 5 people among teenagers who are experiencing these symptoms in the United States. And then introduce the multifactorial model of not just biological, but also psychosocial, cultural, can all be the reasons why someone is feeling depressed, and also evaluating their function, because that really matters when it comes to what kind of treatment that we're going to provide, and also address their trauma and have this trauma-informed approach to be a good listener and to really be understanding where they're coming from. Here are some additional books that you can use for when you're providing psychoeducation for your patients with mild depression symptoms. There are also more resources on our UCSF CAP website. If you click on resources and go down to provider resources, there is a section for depression, and there are a few different PDF that gather all these information, including how to do the initial treatment, and then what are the medications to choose, and what are the information they can share with their patients and families. The additional part of active monitoring and psychoeducation also includes psychoeducational interventions and relaxation skills that we can share with our patients and their parents or guardians. psychoeducational interventions have these following components, including encouraging sleep hygiene, encourage regular exercise, starting healthy diet, at least eating two meals in a day, and journal positive thoughts, track their mood changes. Sometimes that could be helpful for teenagers just to see that changes in terms of what they do and how they feel afterwards. And then you can try to guide them to do more of these mood kind of pleasant activities that will improve their mood, and then also encourage behavioral activation. So sometimes I will sit down with my patient and write down 10 different things that you like to do or things that tend to make you feel happy, and sort of plan that into the next of their week schedule, so that they can incorporate behavioral activation into their daily life. For relaxation strategies, on the right, there are 2 apps that are really widely used, Headspace and Calm. And I often just tell my patients to kind of research that a little bit too. A lot of times they're much better than us in terms of these apps and different kinds of softwares, to encourage them to find one that they like. There are some other skills such as belly breathing, imagining that there's a toy or a turtle on your belly, and then you're moving a toy or a turtle up and down by taking in deep breaths. And there are also progressive muscle relaxation, imagery, imagining a calming place, such as your favorite beach, or using mantra. So for the mild patients, besides providing active monitoring and psychoeducation, the other thing we can do is to connect them with therapy. CBT, cognitive behavioral therapy, and IPTA, interpersonal therapy for adolescents, are 2 evidence. Have desire.
I think you went on mute.
Yes, sorry. I don't know why my Spotify started playing. Are you guys still able to see my screen?
Yes, you're good to go.
Okay, thanks. So for therapy, there are 2 types of therapy that are evidence-based for treating adolescent depression. And note that this is just from research and it doesn't always apply to our real life. A lot of times we may not be able to find or connect our patients with these type of therapists. And also most of the community therapists utilize a model that sort of just combine multiple different models of therapy. So it is still important to connect patients to therapy resources, even if they may not be able to find someone who specializes in interpersonal therapy for adolescents. For moderate to severe patients, that's when we will start thinking about medications. And our SSRI webinar has a lot more rich information of medications, and you may find recording on our website from the SSRI webinar earlier this year. We are today only going to focus on the most evidence-based and widely used SSRI in kiddos and teenagers for depression. They are Prozac, fluoxetine, and then escitalopram, Lexapro, and Zoloft, sertraline. You may note that the starting dose are usually around 50% lower in young kiddos compared to older teens, 13 and up here. So for a younger kiddo, we may prefer starting Prozac at 10 instead of 20. And then for Lexapro, we might start at 2.5 to 5 versus 5 milligram for older teens. And then for sertraline, we will start 12.5 for younger kiddos if they do need the medication, and 25 milligram for 12 and older teenagers. The titration dose are 10 milligram for Prozac, every 5 milligram increment for Lexapro, and then 12.5 to 25 milligram for Zoloft. Here are the FDA approved max doses, and we're really striving for getting to a dose until the patient starts having the positive response, and also slow down or stop the titration whenever there are unmanageable side effects. That being said, we aren't trying to always stay at the starting dose, and we're not necessarily always pushing up to the max dose. We're really trying to find the lowest effective dose for all of our patients. And you will see here are some interesting facts of each medication. So Prozac is the one that has the longest half-life, so it is a good medication if the patient has a adherence concern. And it also tends to be the more activating one. So I will make sure to prescribe Prozac during the day in the morning instead of at night. And then Lexapro tends to be one that has less drug-drug interaction with other medications. So it's a better medication for kiddos that have other kind of medical comorbidities and are taking other types of meds. Zoloft is also known to be milder in terms of the side effect. It can also be slightly activating, so I tend to prescribe it in the morning as well. And then finally, here are the FDA approval for their indication and age. Although these are the FDA approval indications, but these medications have been very extensively widely used in children and teenagers for kind of global anxiety and depression symptoms. So we don't necessarily only limit to the prescribing Zoloft only for OCD. We will also use it for other types of anxiety or depression symptoms. And this is covered in our SSRI webinar as well, but it's just so important everyone will ask about it when we're starting a SSRI for a young person. So just wanted to sort of rehash the SSRI black box warning again. When we're starting an SSRI for a patient, we'll talk to them and their family about black box warning, common and uncommon side effects, and what's going to be the schedule of our future visits. So for black box warning, it was observed that there was increased risk of suicidal thinking and behaviors in youth up to age 24. It was based on 24 trials, some meta-analysis that they obtained data from 4,400 children and teens, and the 9 different antidepressants were included in this study that they observed that there was a 4% versus 2% incidence of suicidal thinking and behaviors. And also what's important was there wasn't any complete suicide. So although it was increased from 2% to 4% of the suicidal thinking and behavior, but it did not lead to any actual suicide. And this is something that I will share with the parent. I don't necessarily share with them these detailed numbers because I find it less helpful. And a lot of parents will start getting more panicked or anxious about, can you provide even more data on each of these antidepressants? And, this is just really from a meta-analysis, so it doesn't really apply to each of our patients. We wanted them to know this collective data that we have and also select the right medication for individuals' needs and their symptoms. For the side effects, here are more 2 common questions that parents or patient may ask about. The first one is they might have heard from their friends or their peers that when they take the medication, it changed their brain, changed their personality, or make them feel like a zombie. So here are the scenarios that I created, and then you may consider using similar language to explain to them that, when you take and we titrate the medication as we discussed, and SSRI in this way don't change one's personality. But sometimes at very high doses, it is true that flattening of affect, kind of apathy and loss of emotions can be observed. And some people have these experiences, but it is reversible. And when we do observe that, then we will get in touch, lower the dose, augmenting with another medication, or switching to something else that may work better for you. The other question that may comes up is after talking about black box warning, then parents would say, does that mean that they should just not take medications because they are fine now and they may become suicidal when they're taking the SSRI? So we will say after the black box warning was issued by FDA in 2004, then we observed that doctors actually feel less comfortable prescribing these medications, and the prescription rate went down. And at the same time, depression and suicidality have increased in the following years. So that really teaches us that depression is worth treating. And the point of having this medication is to make you feel better, not worse. So of course, if you're feeling that you're getting worse, then reach out to us, and then we can meet as soon as possible. Again, don't wait until our next appointment, so that we can discuss any of your concerns. And then we can, again, either lower the dose, augment with other medication, or switch into something that may work better for you. So other things about the side effects of SSRI, there are the common side effects and the less common ones. The common side effects include GI, nausea, vomiting, constipation, diarrhea are the most common. And then also headaches is pretty common. Sleep changes or irritability may occur in the first 2 weeks. And another one is sexual dysfunction that I usually would explain to teenagers when they first start on SSRI, because I want to make sure that they have good medication adherence. So I just want to put it out there in case that if this does occur, then they feel comfortable to bring it back to me and let me know how they feel in terms of the side effects. If the side effects are very mild, then we can continue the medication or figure out ways to mitigate the side effects, such as we can change the medication from bedtime to the morning so that it impacts sleep less. If these medication side effects are moderate, then we will start considering reduce the dose or change the way that we dose it. And if the symptoms are severe, then we'll start thinking about tapering, cross taper to a different agent, and discontinue the current medication. The less common side effects, but more severe ones, are suicidal ideation and behaviors that we talked about earlier regarding the black box warning. In younger kiddos, especially those who are in pre-puberty, activation syndrome is sometimes we get to see that the patient will become restless, pacing around, irritable, having difficulty to fall asleep, getting mad, or sometimes parents describe that it looks like they're manic. It's not real mania, but the sudden surge of serotonin may cause patients, especially younger patients, to have a reaction. And then when it happens, if it's mild, then we will wait. But if it's moderate to severe, they will consider reducing the dose or stopping the medication. And similarly with activation, agitation may be the other one that's less common. Also, SSRI has a low risk of changing platelet function. So people who are at higher bleeding risk will need to think about what would be a better option, maybe choosing something that's a non-SSRI if the patient's bleeding risk is concerning. Hyponatremia, and then finally serotonin syndrome, that the patient may have change in vital signs, heart rate instability, flushing, sweatiness. If it's severe, the patient may need to go to the ED. I always share the common symptoms, common side effects with all of the patients before starting SSRI. I would share some of these uncommon symptoms if I think that is relevant to the patients. And then in terms of scheduling follow-ups after starting the SSRI, based on GLAD-PC, we recommend in the first month, we will start the medication and increase the dose every 2 to 3 weeks if there is no side effect. And in the second month, continue to monitor via phone or messaging every 2 weeks. And we really should start seeing some partial effect in the second month. In the third month, we hope to kind of continue to optimize the medication dose to a therapeutic dose. And then when the patient is at a good dose, that they're experiencing improvement with very little or manageable side effects, then we continue medication at this dose for another 9 to 12 months. And then after that, we can monitor the patient monthly for 6 months. In the meantime, we can start talking about if the patient feel comfortable to stay on the same dose, or they wanted to gradually go down on the medication to really trying to optimize and finding that lowest effective dose. And if they feel comfortable to discontinue the medication because they really have reached full remission and they're in therapy, there are a lot of support in place in life, that's also the time after a year and a half, in the last 6 months, if the patient continue to have stability, then we can taper the medication off gradually. So I find that it's also pretty important and powerful to share with patients that when we start SSRI, it doesn't mean that they need to be on it forever. There is a plan to eventually taper it or lower the dose when their symptoms improve. And based on the TAT study, so this is one of the hallmark studies in pediatric depression treatment, the treatment for adolescent with depression study shows that combining therapy and SSRI is the best option for patients with moderate to severe depression symptoms. For mild patients, we will still continue to use active monitoring, psychoeducation, and potentially connecting them to therapy. Finally, for severe patients, so when to refer them to psychiatry, if the patient has safety concern that they are either at moderate or severe level of suicidal risk, and if there's any significant change in their emotions or behaviors without obvious triggers, there are other comorbid diagnoses such as substance use, psychosis, bipolar disorder, concerns for mania, or the patient have been recently psychiatrically hospitalized or being in the ED. Little improvement with 6 to 8 weeks of optimized treatment or is on 2 or more medications for their depression and it's not improving. If you don't feel like there's any meaningful changes after 2 months, then that's usually the time to start thinking about whether we should refer these patients to psychiatry. And also if the patient has other complex diagnostic issues such as neurodiversity, developmental delay, other complex medical conditions, and also if there's a family history that the patient has poor response to SSRI historically, or if this patient is very young, it's younger than 6 years old, so 5 and under, and these are all pretty legit reasons to start thinking of referring the patient to psychiatry. And CAP psychiatrists can also provide guidance when you're treating mild to moderate patients in your clinic. We can help with making the diagnosis, plan for treatment. We can help with any medication questions with therapy, the type of therapy that they get access to. We also have additional services, including Reach Out and Connect, ROC, psychology consultation, and bridge care coordination from our licensed social worker to provide more community resources. Besides the CAP consultation line, we also have website resources, as I mentioned earlier. If you get onto our website and then look for provider resources, there are several really well managed documents that introduce treatment, management, screening, and resources for depression. So to conclude the take-home messages today, depression is prevalent in youth and now even in younger kiddos. Screening, at least at well visit, is crucial. And the most recommended tool is PHQ-9 for 12 and up. If you have a really young patient, then you can consider using short mood and feelings screener. For youth with suspected depression symptoms, we would just frankly ask about their depression symptoms and somatic symptoms. The key is to kind of get more information about their level of functioning, how functionally impaired that they are at home, at school, at social settings, and also any current or historical stressors and trauma. And then trying to get to understand where they're coming from, having the trauma-informed approach, listening to their stigma, their community kind of background, and their cultural belief will be very helpful for us to make a treatment planning. And then psychoeducation and active monitoring for mild patients, referring all of your patients to therapy if they have access to that. And then for moderate patients, start considering medications on top of therapy. think of Prozac, Lexapro, or Zoloft when you're starting medication for your patients. And then for severe patients, we'll refer them to psychiatry. And in the meantime, if you have any questions, please call us for your questions and we're happy to assist. Okay, I'll turn it back to Joanne.
Wonderful. Thank you so much for this great talk. For all of our participants, please do use this QR code, or I'll throw this link into the chat. And this is how you check in so you can get CME credit for today. But in the meanwhile, since we have a couple of minutes, I'm going to go ahead and start pitching some of these questions to our two speakers. One is, some psychiatrists advocate only therapy to begin with in mild to moderate depression and leaving medications to those who fail therapy. And what are your thoughts on this?
I mean, ideally, we would love to have all our patients seeing a therapist, and we know ideally that's not it's not always accessible. There's definitely a high need for more therapists, and there are more techniques that you can do online, CBT modules as well. We'd always love to be able to recommend, some type of therapy approach first. But active monitoring is also part of the therapy approach, which means sleep hygiene. It's seeking out social supports. It's doing more activation of things like getting out and hiking, music. But we know when we start to see severity of symptoms, then we're going to consider doing the medications. And we may even need to do a medication to even get them to do those interventions. So that's when we start to think about the use of medications. So it's a balancing act. I hope that answers that question. I don't know if anyone else wants to add anything.
Eileen,
Yeah.
did you have something to add?
I agree with Shelly. And I think for mild patients, definitely using active monitoring, therapy, and psychoeducation. When the patients start having moderate symptoms, I think that's the time that we should really think about medication along with therapy, because TAT study, which is a large-scale randomized control study, really shows us that for moderate and severe patients, they do best with the dual treatment.
Wonderful. This is a line stolen from a colleague, Dr. Neil Rojas, who's in developmental medicine, UCSF, is pills don't teach skills. And I think a large part of therapy is really about the skill building. So thanks for that great question. There was a question about, is there an adapted HEADS for school age? And this is from Suzanne Frank, who apparently helped to create this SCHLA in the early 80s, which is great. And this I can open up to the group. Does anybody have a version of the HEADS that they like to use, for the preteen set?
I think Dr. Frank should develop another one. But I did say that we often use a pediatric symptom checklist.
Yes. Is everybody here familiar with the pediatric symptom checklist? Would it be helpful maybe to pull up an example of this? And we can do this while we keep on going on to other questions here. And maybe some of the other CAP staff here might be able to pull the pediatric symptom checklist to share with everybody. So that you have that also as a screening tool. There was also a request to show that a screening tool, here's the pediatric symptom checklist right here. This is also a free, brief screening tool. And the nice thing about it is it screens for a range of behavioral conditions, whether internalizing conditions like depression or anxiety, or externalizing like hyperactivity, impulsivity, non-compliant, disruptive type behaviors. It's wonderful, in that it screens for all of these things. There was a request also to show the screening tools page again. And I don't know if we can go ahead and do that to share that page. But I also want to refer Dr. Sachdeva to look at our CAP website, because all our screening tools are there. And I think we had previously typed that into the chat also. So if somebody could pull that back up to share, that would be fantastic. Okay, other open questions.
think there's also a question about how to taper medication.
Yes, I think that's a really important one. If you could give us like an example of a cross taper that you might commonly do.
Yeah, and I think the person is also asking about converting from one medication to the other.
Yeah.
So if the patient is at a lowest dose of a medication and you're trying to switch to another one, then you can either discontinue it and then start the new one the following week, or you can also direct switch, although there might be a small potential for discontinuation syndrome. So it's either way. There's unfortunately, no good guidelines on how to kind of convert medication from one to the other. But the general approach is you can always taper it down to the lowest dose and then taper it off. And then the following week, you can start the new medication at the lowest dose. Or you can taper it down to the lowest dose, which is the starting dose, and then direct switch to another agent's lowest dose. Either approach is pretty common.
Wonderful. And I did find the earlier slide if this was still helpful. We have like maybe 5 more minutes. If there are other questions, people are welcome. Let me know, and I can actually open up the to let you speak and ask that directly out loud. In the meanwhile, is there another one here? Okay, I think we've answered this one live. Now I have some questions. So with a maximum SSRI dose, do you also decrease that for children under the age of 12, just as you decrease the initial starting dose? Like, can you get all the way up to, like 60 of like Prozac, for example, in somebody under 12?
Not that I know of, but it's a really good question. I think an interesting question. But the reason what I would imagine that it's not modified for kiddos and teenagers may be because kids and teenagers can also be fast metabolizers. So sometimes it is harder to predict how much they would need to reach the maximum kind of effect from a medication. But there is a limitation for the starting dose. And then I would imagine that being related to kids tend to be more sensitive with side effects. So the reason we're always starting at a lower dose for kids and teenagers because they tend to be more sensitive with side effects, and we're kind of testing it out and making sure that they're able to tolerate the medication.
Fantastic. Thanks for that one.
One tip I do have is I often start all my psychiatric medications on like Friday night or Saturday morning if it's a morning dosage medication, just so that we can monitor and understand it for any side effects, so it won't impact school. And then, sometimes I might start an SSRI around like the school vacation break, just so we can monitor more closely too.
Fantastic. And another question that sometimes has come up for me, like, how can you tell if this flat affect of somebody who's like on a mid dose of an SSRI, is that a side effect or is that inadequately treated depression, right? And do you have any thoughts on being able to tell the difference there?
That's a really interesting question. And I wonder what Shelly will think. I think if it were my patient, I would want to try to gather other kind of collateral information of the patient's depression symptoms. And that would really help me to decide whether this flattening effect is from the core depression symptoms or is it from the side effect. Because if the patient has this blunted affect, but all other areas of his or her life have been improving, has been more engaged in school and community, has been able to contact or being like connected with their friends and family, then I may lean towards this being a medication side effect.
Wonderful. Thank you. Looking at the whole picture. I am putting back up the QR code for those who need it. Finally, in the last couple of minutes here, a lot of primary care doctors are afraid of starting SSRIs in kids, not only because of black box warning, but also this fear of inducing mania, right? Of like this switching. And so how can you tell the difference between activation and then this kind of mania? Like, what would you be looking for?
Petra has a really good slide on this when she does her SSRI talk. And activation in the SSRI, it's like pretty sudden when it happens in the first couple of days of starting an SSRI or an increase in the dose. And it's this like, oh, I drank 20 pots of coffee, and it's just complete agitation and activation and moving. And it's pretty consistent. It's all over the place. Whereas like a mania symptoms, when you're activated from the SSRI, you still feel really depressed. But when you're activated from mania, that is your mood changes as well as another part of the symptom.
Okay, wonderful. Thank you. We are just about at time here. So thank you so much, Dr. Wang, Nakaishi, for your wonderful talk today. Thanks to all who were able to join us on in the last part of the summer here. Hope that everybody enjoys the rest of the summer, and we'll see you back next month for our next webinar, which I believe is going to be on disruptive behavior. So take care.